Hello everyone, I am Sylvain Goutelle from Lyon, and I thank the organizer for inviting me to talk about dosing software for optimizing therapy. I apologize for not being able to make this presentation live, but I hope you will enjoy it. So my talk will be divided into two parts. In the first part, I will briefly present the principles of model-based TDM, and in the second part, we will see some illustrative cases. So first, I strongly support TDM, of course, and it should be performed for several drugs, antimicrobial drugs, but it should be recognized that there are some limitations of TDM alone. First, by definition, you can't use TDM before concentration have been sampled, so it cannot be used as a guidance for initial dosing. Second, it is difficult to interpret TDM results when the samples have not been taken at the steady state, which means that it's difficult to perform early optimization for drugs with long half-lives, such as glycopeptides, for example. Also, a difficulty in clinical practice is to interpret concentration measurement when the samples have been taken with deviation from predefined sampling times. And it's a common issue in routine clinical practice. And our colleague Michael Neely showed that only 90% of vancomycin trough in his study were sampled within an hour before the next dose. Also, it is critical for the interpretation of a peak concentration for aminoglycosides, for example, because sampling too early or too low compared with a predefined target can make a real difference. Other issues with TDM alone is the difficulty to manage overexposure, because you can see that the concentration is too high, but you don't really know for how long you should stop the drug, for example, and when you should start to administer the drug again, and at which dosage. So those questions are unsolved with TDM alone, and while they can be solved in part with models. Also, it is also impossible with TDM alone basically to estimate some unobserved quantities that are important in PK for some drugs, such as the AUC, or the time spent above a given concentration threshold, such as the MIC. So basically you cannot estimate AUC or time above the MIC without a model. And finally, without model, it is difficult to get from the result, the drug concentration, to the dosing decision. So what are the principles of PK modeling? Very briefly, I'm quite sure you all know about that. This is a very simple example with a one compartment model, so a mono exponential decline in drug concentration. And what we know about PK is that mathematical models can describe the time course of drug concentration. And so those equations with their parameters can describe the evolution of drug concentration with time. And PK models are so the natural linkage between drug dosage and drug concentrations. This means that if you can identify those equations and those parameters, you will be able to quantitatively describe the relationship between drug dosage and drug concentrations. In routine clinical practice, most often you don't have many samples, many measured concentration. In this example, we have two, for example, for vancomycin, a theoretical example with a peak concentration and a trough concentration. And so the issue for PK modeling, you have to fit a candidate model to data. But there is an estimation issue that there are fewer concentrations available compared with the number of parameters to be estimated. So this issue cannot be solved with a regular or historical regression techniques, such as nonlinear regression. The solution comes with Bayesian regression. The Bayesian principle is based on using prior information, prior PK information about the drug to estimate those PK parameters. So from prior experience with the drug in similar patients, you can say that, for example, for vancomycin, a two-compartment model should describe the data. In this example, you have 5 parameters to estimate. And you can also use this prior information in terms of covariates. So as you know, covariates are clinical descriptor or biological descriptors such as body weight or renal function that are associated, correlated with PK parameters. So in this example, for instance, the volume can be expressed in liter per kilogram of body weight. So the Bayesian approach uses prior information and combine this prior information with individual information to estimate the PK parameters. So the prior information is provided by population PK models from your own activity or from publications, for example. And from this prior information, you can say that there are several sets of parameters that can describe the time course of concentrations, and so several PK profiles that are a priori available to describe your data. And you combine this prior information with the individual information from your patients, which are based on the measured concentrations, of course, and covariate values if they are included in the PK model. And combining those two sources of information, the Bayesian calculation will compute what is called the Bayesian posterior distribution of PK parameters. So what does this mean? This means that from the prior, you have several mathematical solutions to the estimation issue, several sets of PK parameters. In this example, it is a slide from my colleague Michel Todd. 3 profiles may fit the data, but those profiles are associated with different probability for clearance in volume. And in this example, the red profile, the red set of PK parameters has the highest probability. And so the Bayesian calculation will provide you the set of PK parameters that is the most likely and that best fits your data. And so the result of the Bayesian estimation process is to provide individual PK parameters estimated and an estimated PK profile that should best fit your data. So this is indeed the first step in Bayesian regression in model-based TDM. The first step is to identify the PK parameters, as we have seen, but the second step is to make the dosage calculation itself. And basically the principle is to do a model inversion. A colleague of mine from Marseille, Professor Athanasios Iliadis, used to use this sentence, this expression of model inversion. It's really the principle. So once the PK parameters have been identified in your individual patients, you can use those PK parameter values to make a model inversion and to calculate the individualized dosage that is necessary to reach your predefined target concentration. And it's called target concentration intervention. And you can learn more about that by reading paper from our great colleague Roger Jelliffe, which was really a pioneer in this field and who sadly passed away in June this year. So several PK software programs are currently available. They use this Bayesian regression technique, and they can also be used for a priori dosing. About 10 to 12 tools are available, and here are some examples. And of course, there are some differences between those tools in terms of the numbers and the nature of population PK models available. Most of them include models for antimicrobial agents. The user interface, some of them are desktop application, others are web-based. The ability to integrate the tool into electronic health record, and the cost also can be quite different between software. To know more about those specific tools, I encourage you to read this paper, a recent paper in Frontiers in Pharmacology, which is a nice overview of the available programs, and it will give you much more details about the specific features of each program. So let's move to some illustrative cases of model-based TDM from my practice in my center. So our first example is Vancomycin AUC monitoring, and I'm quite sure that most of you have heard about the update of Vancomycin TDM guidelines in the US published this year, which is probably a paradigm shift in my opinion, because it is the first time I think that it is clearly recommended to use the AUC, indeed the AUC over the MIC, as the PK/PD index for monitoring, and it is recommended also clearly to use Bayesian techniques to estimate this AUC. And as you can see, trough-only monitoring is no longer recommended according to those guidelines. So if you want to perform AUC-based monitoring for vancomycin, how can you do that? Here is an example from my hospital. It was an 86-year-old woman with quite low body weight and moderately impaired renal function. This lady had gram-positive bacteremia, and the clinician decided to start vancomycin. And when the treatment was started, we didn't know about the specific pathogen and his MIC, its MIC. So first question from the clinician to our team in the pharmacy department was what should be the best initial dosage? And so we use the software for a priori dosing in this case. So in our department, we have been using the tools from the Jelif laboratory for years. So it was the USC pack for many years, and now it's the best dose program. So my examples are from this package, but others are good also. So for this lady, we calculated the best a priori dosage regimen based on her covariates, so her body weight and her renal function in this example, and the model suggested a loading dose of 1 gram and a maintenance dose of 500 milligram every 12 hours. And according to the model, we should achieve a trough concentration between 15 to 20, the classical target range, and a predicted AUC between 500 and 600. So you can also see with using those tools that TDM remains mandatory for this lady, because you can see what can be the variability in terms of PK profiles from real underexposure to potentially toxic exposure. So TDM is required for this lady, of course. So the treatment was initiated as suggested by my department, with a 1 gram loading dose and 500 milligram every 12 hours as maintenance dose. Drug concentration measurements were performed with a peak and trough, as you can see, at about 24 for the peak and 13 for the trough. So the question is the target AUC achieved, and should the dosage be adjusted? And also with TDM alone and measured concentration alone, you cannot answer the question about the AUC. So with the model, we were able to estimate that the AUC was within the target range, despite quite a low trough. But this is quite common based on literature data, that you can achieve the AUC target despite a trough concentration between 10 and 15 indeed. But as we wanted to reach the trough target as well, we decided to add an extra loading dose of 1 gram and to keep the same maintenance dose. And on day 7, the TDM was performed again and confirmed that both the trough and the AUC targets were achieved. And so we believe that we did a good job for this dosage adjustment. So this is the illustration how you can use those tools to make a priori dose individualization and then to adjust the dosage during therapy. to achieve a target that you cannot estimate without a model, in this example the AUC. Last example, an example of beta-lactam model-based TDM in a younger patient. This patient had augmented renal clearance, augmented renal function with creatinine clearance of 150 milliliter per minute. He was hospitalized in the ICU for pulmonary infection caused by Pseudomonas aeruginosa with an MIC of 8, a high MIC for this pathogen. And he was under cefepime at 2 grams every 8 hours as a 3-hour infusion. But the patient was still febrile under therapy, and the clinician contacted us to see what she could do. So we suggested her to do TDM to get some measured concentration, and then we were asked to interpret the results. So some exposure targets have been defined for cefepime, and especially in a critically ill patient, you should spend 100% of time above the MIC as the free drug concentration, so the unbound concentration should be above the MIC 100% of time. And on the other side, the trough concentration should be below 20 to minimize neurotoxicity. If you consider the MIC of 8 for this patient, this means that the trough concentration should be between 10 and 20. And so in this example, the MIC make a great difference, because this means that basically cefepime is a narrow therapeutic margin drug in this case. We had a cefepime concentration measurement available, and so the result was 7.9 milligram per liter. But look at the time. It was sampled too early, 6-hour post-dose instead of 8. And so, of course, you can assume that the real trough should be lower, but you don't know how much. So we performed a PK analysis for this patient, and we were able to estimate the real trough at 8 hours at 3.2 for the total concentration and 2.6 for the unbound concentration. And we estimated that the time spent above the MIC for the free concentration was only 65%. And so we calculated that an extra dose was necessary and suggested 2 grams every 6 hours as the future dosage regimen. So this illustrates again the strength of this approach for estimating unobserved quantities and to interpret drug concentration measurement when they are sampled with deviation from predefined times. So my take-home messages at the end of this presentation is to say that TDM is most useful but has some limitation for precision dosing. I encourage to use PK models because they are the natural linkage between drug dosages and concentrations of drugs. PK software tools are now available, and all of them include Bayesian regression, which is a state-of-the-art approach for parameter estimation and model-based dose adjustments. To conclude, I strongly believe that MIC determination combined with measured drug concentration and PK modeling are real step towards and necessary towards real precision dosing of antibacterials. I thank you very much for the invitation, and I thank you all for your attention. Have a nice workshop. Bye-bye.